Good evening and welcome. Tonight we delve into a profoundly significant and often emotionally charged subject, the concept of presumed consent, or an opt-out system, for organ donation after death. The core tension lies between the potential to dramatically increase the availability of life-saving organs and the fundamental principles of individual autonomy and explicit consent. Joining us to dissect this complex issue are two distinguished voices. Mr. Samuel Jones, who will argue in favor of the opt-out system, and Ms. Isabella Rossi, who will present the case against it, championing the necessity of affirmative consent. We will begin with opening statements, followed by rebuttals, a moderated discussion, and concluding remarks. Mr. Jones, you have the floor.
Thank you, Dr. Reed. The situation we face regarding organ availability is nothing short of a public health crisis. Thousands of individuals perish annually whilst awaiting a transplant, a tragedy compounded by the knowledge that many of these deaths are potentially preventable. Implementing an opt-out system for organ donation is, I contend, not merely a pragmatic solution, but an ethical imperative grounded in societal solidarity and compassion. This approach fundamentally reframes organ donation not as an exceptional act, but as a default gesture of civic goodwill upon death, a final contribution to the collective welfare. Evidence from jurisdictions like Spain, Belgium, and Wales, which have adopted variations of presumed consent, consistently demonstrates a significant uplift in donation rates compared to opt-in systems. This isn't conjecture. It's evidence-based policy demonstrating tangible, life-saving outcomes. Crucially, the opt-out model does not abrogate individual autonomy. Rather, it respects it through a clearly defined and accessible mechanism for individuals to register their dissent. The right to refuse remains absolute. What changes is the default assumption, shifting it towards a position that maximizes the potential for life. We must consider this a matter of pragmatic compassion. It acknowledges the inertia often present in opt-in systems, where good intentions don't always translate into registered consent, and structures the system to align with the widely reported public support for organ donation. Addressing the organ deficit requires bold, systemic change. An opt-out system represents a responsible, ethical, and ultimately life-affirming policy choice, reflecting a societal commitment to mutual support and the preservation of life.
Thank you, Mr. Jones. Ms. Rossi, your opening statement, please.
Thank you, Dr. Reed. While the objective of increasing organ availability is undeniably noble, the proposed method, presumed consent, raises profound ethical and legal objections centered on fundamental human rights. At the heart of this issue lies the principle of bodily autonomy, the inalienable right of individuals to control their own bodies and make decisions about their medical care, extending even beyond death. Consent, to be ethically valid, must be explicit, informed, and freely given. It cannot, and should not, be presumed from silence or inaction. The assertion that silence equals consent fundamentally misunderstands the nature of consent itself. It transforms a deeply personal gift into a state-mandated default extraction. Implementing an opt-out system represents a significant state encroachment into one of the most private spheres of individual life, what happens to one's physical remains. It shifts the burden from the state needing permission to individuals needing to actively refuse, potentially violating principles of self-determination. Furthermore, we must consider the potential disparate impact on vulnerable populations. Individuals with lower levels of literacy, limited access to information, language barriers, or cognitive impairments may struggle to understand the implications of the system or navigate the opt-out process effectively. This creates a substantial risk that individuals who would not have consented might have their organs donated simply due to a failure to register their objection, which constitutes a form of systemic coercion, however unintentional. The notion of quote, or fictitious consent is ethically tenuous. True consent requires a conscious act of willing. Relying on a default assumption, even with an opt-out clause, undermines the moral significance of donation as a deliberate act of altruism. Bodily integrity and the right to determine what happens to one's body are paramount. They should not be overridden by perceived societal benefit or governmental convenience.
Thank you, Ms. Rossi. Mr. Jones, you now have the opportunity to respond to Ms. Rossi's points.
Ms. Rossi raises important points about autonomy, but I believe the characterization of an opt-out system as a violation of this principle is a misinterpretation. Autonomy is fundamentally about the capacity to choose. A well-designed opt-out system explicitly preserves this capacity by providing a clear, accessible, and universally communicated mechanism for refusal. The state is not compelling donation. It is establishing a default position that reflects overwhelming public sentiment in favor of donation, while rigorously upholding the right to dissent. To frame this as state encroachment seems disproportionate when compared to numerous other areas where defaults exist for public good, such as certain health screenings or retirement savings plans, which also feature opt-out provisions. The crucial difference here is the scale of the potential benefit. Saving lives currently being lost. Ms. Rossi rightly mentions the need to protect vulnerable populations. This is not an argument against the system itself, but an argument for its careful and equitable implementation. Robust, multilingual public information campaigns, community outreach programs, and easily navigable opt-out registries, both online and offline, are essential components, not insurmountable obstacles. Indeed, countries with successful opt-out systems have invested heavily in precisely these measures. We must weigh the ethical considerations. Is it more ethically sound to maintain an opt-in system where inertia and lack of registration lead to preventable deaths, or to adopt a system that presumes solidarity, a presumption rebuttable by individual choice, and demonstrably saves more lives? The human cost of the status quo, measured in thousands of lives lost on waiting lists each year, cannot be ethically ignored. The principle of beneficence, the duty to do good and prevent harm, strongly supports exploring policies with proven life-saving potential. The opt-out system, implemented thoughtfully, balances autonomy with a profound commitment to saving lives that would otherwise be lost.
Thank you, Mr. Jones. Ms. Rossi, your rebuttal.
Mr. Jones paints a compelling picture of lives saved, and again, the goal is shared. However, attributing increased donation rates solely to the legislative change to opt-out systems oversimplifies a complex reality. Studies, including analyses of the Spanish model often cited, suggest that concurrent factors like significant investment in transplant infrastructure, specialized coordination teams within hospitals, and enhanced training for medical staff play a crucial, perhaps even dominant role. Isolating the legal framework as the sole or primary driver of success is methodologically challenging and potentially misleading. But even if we accept that opt-out systems contribute to higher rates, the fundamental ethical objection remains. The ends, however desirable, do not justify ethically questionable means. Violating the principle of explicit affirmative consent for something as deeply personal as organ removal is a line we cross at our peril. Mr. Jones speaks of the symbolic importance of solidarity, but I argue there's immense symbolic, and indeed practical, importance in the act of giving consent. It affirms individual agency and the altruistic nature of the donation. Presuming consent diminishes this. It reframes donation as a civic duty expected by default, rather than a profound gift offered by choice. Regarding the practicalities, the idea of a perfectly functioning, universally accessible, and error-free opt-out registry is optimistic, to say the least. Maintaining such a database requires constant updating, robust data security, and mechanisms to ensure every single person is aware of the system and how to register their preference accurately. The potential for administrative errors, database failures, or individuals simply falling through the cracks is significant. Furthermore, the role of the family cannot be understated. Even with an opt-out system, situations inevitably arise where the deceased hasn't opted out, but the family vehemently objects based on known, perhaps unregistered, wishes or deeply held beliefs. Proceeding against the family's wishes in such circumstances can cause immense distress and potentially erode public trust in the medical profession and the donation system itself. Many opt-out systems in practice still defer to strong family objections, which somewhat undermines the, quote, presumed consent principle. Building trust, enhancing education within an opt-in framework, and improving hospital processes for identifying potential donors and approaching families sensitively seem a more ethically sound path forward.
We've heard compelling arguments on both sides regarding the core principles and potential impacts. Let's move to a brief discussion focusing on practical implementation and alternatives. A question for both of you. Beyond the core principles we've debated, what specific practical elements, such as public education, registry management, or clinician training, are most critical for the ethical functioning of any organ donation system, and particularly an opt-out one? Are these realistically achievable to the standard required, Mr. Jones?
Certainly. For an opt-out system to function ethically and effectively, several elements are non-negotiable. Firstly, sustained, pervasive, and culturally sensitive public education is paramount. This isn't a one-off campaign. It requires ongoing effort through multiple channels to ensure awareness penetrates all demographics. Secondly, the opt-out registry must be impeccably managed, secure, easily accessible, online, offline, via healthcare providers, and regularly audited for accuracy. Thirdly, healthcare professionals need thorough training not just on the legalities, but on sensitive communication with families, respecting both the deceased's registered status, or lack thereof, and the family's grief. These are challenging but absolutely achievable, as demonstrated by countries that have successfully implemented such systems.
Ms. Rossi, your perspective on these practical necessities.
I agree that those elements, education, registry integrity, and clinician training, are vital regardless of the system. However, the burden of perfection is significantly higher, and the ethical stakes of failure far greater in an opt-out system. Any lapse in education or registry access directly translates into potentially violating someone's bodily autonomy without their explicit consent. While these elements are crucial for opt-in systems too, the consequence of failure there is a missed opportunity for donation, not a potential violation of a fundamental right based on presumed intent. Achieving the near-flawless execution required for an ethically sound opt-out system across diverse populations in complex healthcare infrastructures presents formidable, perhaps unrealistic, challenges.
Ms. Rossi, if you maintain that opt-out is ethically unsound, what specific, effective measures should be prioritized within the current opt-in framework to genuinely boost donation rates?
There's considerable scope for improvement within the opt-in model. Firstly, massively enhancing public education about the need for donation and, crucially, the ease of registration. Secondly, implementing required referral policies in hospitals, mandating that potential donors are identified and donation organizations are notified promptly. Thirdly, investing heavily in training specialist nurses or coordinators to approach families with sensitivity and expertise. Fourthly, making donor registration incredibly simple and integrated into everyday processes, like driving license renewals or health checkups. Focusing on optimizing these aspects respects autonomy while actively working to increase the donor pool.
And Mr. Jones, a final question in this section. How can an opt-out system sensitively and effectively address situations where an individual hasn't opted out, but their family expresses strong objections based on religious or cultural beliefs unknown to the registry?
This is undeniably a sensitive area. Most established opt-out systems incorporate a soft element, allowing for family consultation. While the legal default might be donation if the individual hasn't opted out, compassionate practice often involves discussing the situation with the family to understand their perspective and the deceased's likely unexpressed wishes or values. If there's strong evidence presented by the family about the deceased's beliefs opposing donation, even without formal opt-out, healthcare teams guided by ethical protocols may decide against proceeding. It requires nuanced guidelines and highly skilled communication to balance the default position with respect for family grief and potential unrecorded objections.
Thank you both. We now move to closing statements. Ms. Rossi, please summarize your position.
In conclusion, while the aspiration to save more lives through organ donation is universally shared, the mechanism of presumed consent or an opt-out system remains fundamentally flawed from an ethical standpoint. It compromises the bedrock principle of bodily autonomy and the necessity of explicit, affirmative consent for any medical procedure, particularly one as significant as organ removal. The reliance on presumed intent derived from silence is ethically precarious and risks disproportionately affecting vulnerable individuals who may not effectively navigate the opt-out process. Furthermore, the practical challenges of maintaining a perfect registry and the potential for causing profound family distress or eroding public trust cannot be dismissed. Increasing organ donation is a laudable goal, but it should be pursued through means that unequivocally uphold individual rights and the principle of informed choice. Enhancing education, improving opt-in registration processes, and investing in hospital infrastructure and family support within the current framework offer a path forward that is both effective and ethically sound. We must prioritize strategies that encourage donation as a conscious act of generosity, not as a state-presumed obligation.
Thank you, Ms. Rossi. Mr. Jones, your closing statement.
Thank you. Tonight we've debated a critical choice. Continue with an opt-in system that, despite best efforts, consistently leaves thousands waiting and dying, or embrace a system proven elsewhere to significantly increase organ availability. The opt-out system I maintain represents a pragmatic and ethically responsible evolution. It aligns the default position with the overwhelming public support for donation, transforming good intentions into life-saving actions. Crucially, individual autonomy is not sacrificed. It is explicitly protected through the right to opt out. This system respects choice while maximizing the potential for good. Concerns about implementation, while valid, are addressable through robust public education, meticulous registry management, and sensitive protocols for family engagement, challenges that have been successfully met in other nations. This is not about state coercion. It's about structuring our systems to facilitate the gift of life more effectively, based on a rebuttable presumption of solidarity. The ethical imperative lies in action. Faced with a persistent organ deficit and the human tragedy it represents, adopting a carefully implemented opt-out system offers the most promising pathway to honoring both individual choice and our collective responsibility to save lives.
Mr. Jones, Ms. Rossi, thank you both for sharing your deeply considered perspectives on this challenging topic. You've illuminated the profound ethical considerations surrounding presumed consent, balancing societal benefit against individual rights. Thank you to our audience for joining this vital discussion.